this strategy highlights customer and societal impact through excellence and science and technical competencies. And then VTT is also quite active in spinning out new companies from VTT's portfolio and IPR. And as I said, health and health-related technologies are one of our key research areas, and this is growing quite fast in Finland and also in VTT's research portfolio. And we all know that quality and cost of healthcare is extremely important to develop future healthcare systems and healthcare solutions in Finland, in Europe, and globally. In our healthcare research, we help our customers to develop new technologies and service concepts in the area of digital health, but also in nutrition and topics like that. Our research is focusing on health monitoring, human data analysis and application and service design. And what we are doing, we are developing tools and services that enable smart decisions for health and well-being, and intelligence products help individuals and professionals to better understand and manage individual health-related behavior. In the future, we envision that people are empowered to take care of their own health and well-being as a whole. And we all know quite well that one important aspect in healthcare development is policy implications and how political decision-making can help to improve healthcare and healthcare systems and their development as a whole. And this is a big issue in Finland and all different kind of countries. And it's really crucial that political decision-making is based on facts and things like that. And that's why we need data-driven decision-making. And for reaching that, we need the combination of data analysis with expertise in foresight and modeling in social technical problems. And that's why we are also integrating in this MIDAS concept, this data analysis and foresight activities. And in healthcare domain, there is a lot of unused data, and that's because of the fact that many of the data sources are existing in silos, and there is a lot of possibilities to combine and integrate data, and that's creating a lot of new opportunities. And informed data-driven decisions making requires understandable data analysis and visualization tools, and today the speakers are focusing on these kind of topics around this MIDAS Project Consortium. So I think that was a short opening for this meeting, and it's great pleasure on behalf of VTT to hope you a great seminar and kick off the real expert talks. Thanks.
Thank you very much for the introduction. Can everyone hear me okay as well? Yep. I'm from Belfast, so I'm very loud, and I also speak very quickly, but not as quickly as Michaela, who will speak next, or Johnny, who will probably speak later. So if you have problems with keeping up with how quickly I speak, please let me know, and be worried about how much more difficult Michaela will be. I'm going to kick off this session. Well, actually, I'm going to kick off. I'm going to kick off this session by killing my computer. I actually just got this computer last week because my PC kept dying on me and repeatedly did it during conference presentations. And the first time I've gone to use this for a conference, I thought it had just done the same. But anyway, so I'm going to kick off this session and finish the session. I'm going to start out with a very brief introductory presentation that we've entitled Demystifying Big Data. We'll then have a talk from Michaela about the MIDAS project. We then have Marita and Mina talking about the Finnish examples. And then I'm actually going to finish up with a project that we had done looking at the sort of outcome that we expect to see from the MIDAS project with some work that we've done internally and with the team in Ulster. So to start out with, I want to give some very simple overview slides about big data to hopefully make this a little more simple and to make a little more sense. I come from Analytics Engines. I'm the head of life science and healthcare there, and we are a big data company or a big data analytics company. And when I joined the organization, I was not 100% sure really what people meant by big data. I come from a biology background where we do a lot of next generation sequencing, and we're used to big data just meaning lots and lots and lots of data. But it's not quite as simple as that. And actually, as we look to healthcare, it's not the volume of data that is necessarily the big problem. People talk about the V's of big data, and I apologize for this being partially in Spanish. It is an international consortium, so I've decided to use random languages on my slides. But people talk about the 4 V's of big data. I've also heard this extended to 6, but that's just unnecessary. What we're really talking about is volume, variety, velocity, and veracity. So when we talk about the volume of data, I'll come to that in a minute because it's probably the most simplistic. But within healthcare, I think the biggest challenge is actually the variety of data. And I've given an example here on the top right that kind of highlights this to an extent. As I say, my background is actually biology. So I started out working in a lab, and I've plenty of experience working with pharmacies and with primary care. And I know for a fact that even within labs, our data is fractioned and siloed. But in reality, the data that sits in labs, the data that sits in primary care, the data that sits in hospitals with specialists, in long-term care, in public health, in pharmacy, this data is completely siloed, not just from each organization, but often even within those organizations. And what we're trying to do with MIDAS and with most big data analytics projects is to try and actually get value from bringing this data together. That brings us to the one other V that I will accept beyond veracity and velocity, and ultimately its value. And what this all boils down to is that we generate lots of data, it is siloed, but ultimately we believe there's a lot of value in this data, and that's what we're setting out to try and achieve with this project. I mentioned that I would come back to volume, and I can't not do this because I'm a geneticist, so I have to mention it. When we look at the volume of data that's being generated routinely, this has actually grown and is growing an astronomical amount. When I started working in labs, we were doing DNA sequencing, and I would generate maybe 15, 20 kilobases of data after a hard day's work. When we generated the human genome, it took 13 years and cost $3 billion. But now we can actually generate that same information in a day for about $1,500. And that growth of data that we're seeing is increasingly difficult to deal with. A single genome is 800 megabytes. 20 cancer genomes can be up to 300 terabytes. And we look at all of the known variants, and we look at things like the Broad database and the Sanger database. We are looking at petabytes of information. So this is information that is no longer something that I can deal with on my laptop, even if I had the intelligence to do that. There are a lot of changes in healthcare as well. I've noticed across the board that increasingly people are talking about outcomes-based healthcare. I've also heard people talking about outcomes-based government and outcomes-based marketing, and I think we've developed an obsession with outcomes-based everything. But realistically, I think it's of most importance within healthcare. There's been a large move within the US, where I've spent a lot of my career working with pharmaceutical companies and with hospitals there, focusing on better understanding the outcomes and the value for patients. And there's an attempt to move away from transactional healthcare to outcomes-based healthcare. This has been highlighted by the fact that Medicare and Medicaid, the 2 biggest single payers within the US, have actually got to a point where they are now beginning to fine hospitals for readmissions for the same condition. Now, if you actually talk to people in the finance departments of those hospitals and the program managers, they are accepting that over the next few years, they will have to just take those fines as part of the cost of running business, because they haven't figured out how to truly transform healthcare in a way that will actually avoid that. My background is also in personalized medicine, where again, I keep mentioning genetics. It's not part of the MIDAS project. It's just something I'm comfortable with. But ultimately, personalized medicine is another key driver of the use of big data. When we talk about personalized medicine or participatory medicine or preventative medicine or any of the P's of personalized medicine, We are looking at bringing the patient into what we look at for healthcare. So it's things like MyData. It's giving patients ownership of their data. It's giving them better understanding of their data, but it's also generating huge volumes of data that need to be understood by everyone within the healthcare sector to deliver these value-based or outcomes-based healthcare. So what is the potential? We're already generating this large quantity of data. We've got the outpatient records, inpatient records, billing details, claims, labs, clinical trials, and very commonly we're pushing all of this into an enterprise data warehouse. But ultimately, what are we getting out of that? What's coming out of the enterprise data warehouse? And that's the key point of what we need to try and understand. We are coming from a position, and this is this kind of mapping of the different levels of the use of data within healthcare. Most people are coming from a place of level 0 where they've got fragmented point solutions, or many people have enterprise data warehouses that are being used to a greater or lesser extent. In some places we've moved beyond that and we've started to put in things like standardized vocabularies and patient registries. Some people are using things like SNOMED to ensure that we can use similar ontologies across hospitals, across health systems. And once we've done that, that's when you can start to look at things like automated internal reporting, which tends to be focused on cost and waste reduction. It's trying to understand how well we're delivering a service. The next level up from that is something that's probably less commonly used, but definitely happens. And that's where we've actually got automated external reporting. That's when there's a level of transparency introduced within healthcare, where people from the outside world can look to the health system, can look to a hospital, can look at a GP surgery, and actually look at information coming out regarding the quality and the standard of care that's delivered from that organization. A lot of that still focuses, though, on waste and care variability reduction. And I'll be honest, most of this is driven from the American market, where it's very economically driven and it's driven by private payer associations. Coming from the UK, where we have the national health system, there is a desire to obviously reduce waste and improve care, but because we don't have as competitive an environment for healthcare delivery from a payer perspective, it's not as big a focus, which on the one hand may be seen as bad, but from a personal perspective, I believe it's good. Because when we look at the US market for health analytics in the US is focused around money. It's not focused around patients. It's not focused around improved care. It's focused around reducing costs and reducing wastes. What I think we really need to be focused on and what we should really care about in healthcare is level 6, 7, and 8. It's when we look at population health management and suggestive analytics. We look at clinical risk intervention and predictive analytics. And ultimately, what I believe is the future for the healthcare systems across the board, it's when we have true personalized medicine and prescriptive analytics. Now, this sounds to some almost like a pipe dream. You know, this perhaps is in some people's roadmaps so far out that it seems that we may never actually get to this point. But I want to go through a few examples of where I feel that today we are actually achieving this within certain healthcare systems. I noticed the guys from IBM are here because Watson is a big part of that in many places, but I'm sure they'd be happy to tell you more about that later. When we look at the impacts, this is something that was published in Harvard Business Review last year. And it was a couple of these figures really jumped out at me. So the first one is looking at the benefits of big data. And the most common answer in terms of what people believe the benefits will be is that 63% believe that it will help track and manage population health more efficiently. And I think that's very telling. So the most common belief that people have big data will help them achieve is better care, better population health. The next most common at 62% is it will significantly improve patient care within the military health and VA systems, again highlighting this is very American focused. And 60% believe it will enhance the ability to deliver preventative care, which again is another very positive thing. We are looking at trying to look at not just personalized medicine, but preventative medicine. When we look at analytics, moving beyond the simplicity of linking the data together and actually trying to get value and insight from the data, this is where we start to see really interesting stuff. 66% of those polled said that they would use analytics to identify at-risk patients. My background is in the diagnostics industry, and that's exactly what we were focused on. We were using big data, using genomic information to identify patients who were at a higher risk, to get earlier diagnosis, and to an extent predicting the onset of a more serious disease based on an earlier stage. 64% were focused on tracking clinical outcomes. This is actually one of the biggest challenges, I believe, within healthcare, is that to have an outcomes-based system, we have to have some way of actually understanding and measuring the outcome. This idea of having a transactional system where a patient arrives at a hospital, is treated and is released, doesn't actually tell us whether the patient got the standard of care that they required. And the reason that in the US market this is quite challenging is because if you go to a hospital and you receive care and you're released and you need to go back to hospital again because your treatment didn't work, you may actually go to a different hospital because you're choosing a better hospital. And the actual hospitals themselves may not have the data. The payers will have that data, but your hospitals may not. So actually using analytics to track the outcomes is very important. 64%, sadly, are still looking at big data and analytics as a way of doing performance management. I think that's an inevitability. It's one of those things that we're obviously going to be focused on patient care, but we kind of, to do so, have to look at our own selves internally and figure out how well we're delivering that care. So analytics will still be used in that setting. But ultimately, I think what's probably the most interesting is this 57% who see analytics as a way of helping clinical decision-making at the point of care. And so the last couple of examples I want to give are real-world examples where this is not a pipe dream, this is being done today. So the first one, I've chosen a deliberately probably challengeable one or controversial one. It's Google and the work that they've done with the Royal Free Hospital. Now, I've already heard this mentioned today in our meetings by the head of our policy group, who's highlighting that this is an example of what can happen when you don't properly follow ethical guidelines and policy guidelines. Google have got in a lot of hot water and got a lot of bad PR for what they've done with Royal Free, which involved them accessing huge amounts of patient data. It's important that we recognize the challenge around data access, but it's also important to actually look at what Google were doing in this case, or what DeepMind were doing. This project sets out to analyze lab results and identify acute kidney injury as early as possible after a patient receives any form of treatment. Now, if a patient is in hospital and is put on a heavy antibiotic like gentamicin, any early detection of acute kidney injury is going to result in immediately stopping that gentamicin treatment and monitoring that patient more closely. Acute kidney injury, AKI, actually kills a significant number of people each year. So what this is doing is actually saving people's lives. It's actually alerting clinicians, it's alerting medics to the fact that a patient is actually at serious risk whilst in hospital and whilst under your care. So while there are a lot of interesting factors around privacy and ethics with this project, there's also a lot of good that comes out of it as well. The second one is something that seems perhaps a little facetious, but actually is really fascinating. One of the challenges in healthcare in the UK particularly is actually the shortage of healthcare professionals that are available. It's the amount of time it takes to get an appointment with a GP or the amount of time that people sit on waiting lists. A few years back, the NHS introduced a system where people could have a non-emergency phone-in service that it turned out were manned by rather poorly trained staff and often very, very understaffed. And there were cases of people, well, there were some very negative cases in the press of where this system did not work and in fact had caused serious problems. The worst I saw was an investigation that went on of people who were having callers phoning in who were suicidally depressed, and the people answering the phone didn't know what to do and were putting them on hold until they hung up. What Babylon Health have done, and this is now being implemented within London in the NHS, is actually to replace this telephone helpline with an AI-powered chatbot that people can use on their phones. Now, this is quite interesting. There are 10,000 known human diseases, but realistically, even a skilled doctor is only going to be able to recall a fraction of those at any given moment. Now, if we forget about a skilled doctor with 20 years experience and look to a 21-year-old who's had 6 weeks of training, who's answering the phone line, there's going to be a huge challenge there. What the Babylon Health application does is actually essentially creates a huge corpus of data that is trained on an ongoing basis on what's coming in, and it's actually using AI to help deliver people information about what kind of care that they need, again in a non-emergency setting, but often able to give them advice as to when emergency care is actually needed. The final example that I want to use is actually something that was approved very recently. As I said, I actually come from the diagnostics industry, and about 6-9 months ago at this point, this company, Arterys, received approval for what they call a software as a service analytics platform based on cloud computation that revolutionizes medical imaging. What's behind this is actually more interesting. This entire clinical diagnostic test is based on deep learning and it identifies cardiac issues. And this has been trained on just a couple of hundred samples, but is now categorically showing better performance than most routine clinical tests. It's been repeatedly validated and it is now FDA approved via the 510K pathway. So if anybody knows anything about medical regulations, I would have expected this to go down the PMA pathway, pre-market approval, and to take 5 years. It actually was managed to get through on a 510K, which means it's considered substantially equivalent to something that's on the market. So we now have something that is a cloud-based platform using deep learning, the most cutting edge of machine learning and artificial intelligence, and it's actually been able to get itself onto the market with not a huge number of patients, enough validation to show that it works incredibly well, and 2 to 3 years faster than anyone would have expected. And I actually, even coming from this background and having a passionate interest in machine learning, I thought this was 5 to 10 years away, but it's actually on the market now and is being used in routine care. So in conclusion on this part, big data is already improving healthcare, and it really is just the beginning. I've chosen just a few examples there. There are countless more, but really this is just starting. I think that data and analytics generally have the potential to utterly transform healthcare and improve data-driven healthcare policy. And ultimately, this is what leads me on to Michaela's talk on the MIDAS Project, where we are aiming to move data-driven healthcare policy out of silos and into an EU-wide initiative. So at that point, I'd like to ask Michaela to come up and give an overview on MIDAS.
You keep doing it. Okay, folks, my name is Michaela Black. I'm from Ulster University, and I'm here presenting MIDAS as part of the MPI of the project. As you'll see as we go through, the project is a large consortium of now 70 plus members. And it's a really nice consortium to be part of. Can I just start first of all by thanking VTT for actually helping organise, doing most of the organising, and you have particularly, for setting this next 2 days up, for VTT for hosting us and having us all here. Thank you very much on behalf of the whole consortium. So I'm going to start off just really with an outline. I'm going to talk about some of the strengths of the MIDAS project. I'm going to give you a review of the consortium partners. I'm going to look at the project approach, some of the work packages, and again, one of the valuable strengths I think we have is the policy board, who are actually members of our consortium as well. Those are our health practitioners, and then the policy board benefits. And I'm going to show you some of up to date what we were getting out of the project at the minute. And as Austin says, if I'm talking any faster than Austin, if you just give me a signal, I will slow down. So project review, again, we spent a good 68 months on writing this project, and quite a strong team. We scored 15 out of 15. It will be 6 months of our lives we will never get back, but it's been well worth every minute of it. We were allocated 4.5 million for the project over a duration of 40 months. It's a very, very strong consortium, and even from some of the deliverables and the showcases that we've seen today and some of the demos, that's very, very apparent. We've got a very strong academic set of partners. The technical partners are exceptional. And again, we have this real added value by having the policy board on board, giving us the user requirements and feedback the whole way through. And that is adding to the real value of the project. We have great opportunities in the project for improved policy for health using big data across Europe. And as Austin has already shown, there are great opportunities there, and the more we can build upon that and roll that out across Europe, the better. High impact for research for both the academic and the technical partners, and also even for the research active members of the policy board. And again, we have high impact for this potential and what we can get it. And again, learning from each other, and you'll see later on, Mina and then we'll be talking about the My Data. There's huge potential to roll that out across Europe. So this is sort of just a quick map of where the partners are from. In the UK and Ireland, we've got ourselves, we've got the Technical Team Analytical Engine, we've got Public Health England doing some work in the UK. We have our policy board members, our Business Service Organisation and Southeastern Trust. We also have involved Arizona State University, and Raghu is here today, and it gives us a very nice comparison with ourselves and what is going on in America. We have technical partners from IBM, from the south of Ireland, and we also have DCU involved as an academic partner. And then in Spain and the Basque region, we have Vicontech and BioF. We have Quinn Intelligence here today, who are from Slovenia, one of the technical partners, and we also have academic partner KU Leuven involved here today. And then again, we have VTT involved. We've got THL as our partner and the University of Oulu. So it is quite a good spread of a consortium, quite well across. And again, it gives us the opportunity to roll out any of our findings of the project. So the left-hand side of your diagram you will see is really just the scientific and technical team that I spoke about, and the policy board are those members on the right-hand side. So from each region that we have a technical or academic team, we have also got some health partners involved to help us roll out what we're doing and have input from the health partners there. This is really a brief overview of what MIDAS is actually really all about. So what we really want to do is take heterogeneous data from multiple sources. So you can see here, we want to take some sepsis data, self-care data, social housing, any sort of aspect of data that we can get our hands on from the policy board. And they do not, and one of the problems, particularly if we look at just Northern Ireland alone, these health practitioners are some of the best data collectors we have, but they are collecting data in heterogeneous sources. So they're sitting very disparate data, they're not connected, and they do not have the financial money to redesign their architecture and restore it. So it's not a Google and it's not an Amazon. They want to put the money into the healthcare, and we need to be able to help them connect this data and get better value out of it. So the sources of data that we'll be getting, there's no limitations with the solution that we're giving them. There's no implications of cost and re-architecture in any of their facilities. What we want to do then is do the collection of this for them and then open up, do some data preparation on that and validation, and then open up a suite of data integration, analytics and visualization, so that they can learn more from their data, and actually then when they're moving forward with their policies have the data to show that that's the right policy to go with. And then when they do move forward with the policy, they can collect the data to evaluate and make sure that that policy was the right, it's moving in the right direction, or do we need to do some tweaking. So it's closing the loop that at the minute the health services don't have. What we want to do is have our empowerment for our citizens and our policy makers at a localized level. So the platform will have data from the policymakers, so we're looking here at ministries and departments and health. We'll also be looking at our data providers locally from our trusts and health providers. The citizens, as Mina and them are going to talk about later, we're looking into citizens and themselves volunteering some of their data to help us with our health research, and then the solution drivers. So this is where we're adding the analytics, the data connection layer, and the visualization. So what we're trying to look at is we started off with a problem where we have an increase in aging population, we have less resources and finances in healthcare, and you have this very fractured and heterogeneous data for policies. And where we want to get to is we want improved data access for everyone. We want enhanced policy creation and effectiveness, and we want that empowered patient. And to get that, we really need 4 layers. We need to be able to access this heterogeneous data sources, number 1, including governance and consent, and also looking at open source data. We want to bring in a more richness of the data and add that. So no limitations to type or sources of data we can bring in. We need to offer this data connection layer. This is the key thing that the health departments do not have, and that they are not able to connect this heterogeneous fractured data, and we need to be able to do that easily for them and at low cost. And then apply the analytics and the visualization so that they can view any learning of knowledge or information that we have from that data. And that's really what MIDAS as a solution is going to provide. So we have our data sources. It could be open data, my data, and again, all of the health data. The one thing that we're looking at as well in this project, we're setting aside a work package just to look around consent and governance, because that has a huge implication when we're bringing all of this data together and any knowledge that we'll be extracting from it. We're going to connect internal and external data sources through the technical consortium. Then we're going to apply the machine learning, forecast and simulation, and that will then allow the policy review for the policy level people looking at the effectiveness of these policies. And this is just a quick overview or visualization of what will happen. So these are your different segregations of data, and again, they don't have to be the same type. You can have a DIP file, CSV files, you can have image files, all ranging different files, and at this stage they're not connected at all. And what we're offering is this virtualization layer that comes in at the top, offering the connections, and sitting on top of that will be our analytics and visualizations. And again, this platform is going to be delivered in 4 of the key areas within the project. What we want as an output is a better, improved policy process, a closed loop of it. And what we don't have at the minute is we're missing this end part. So in Northern Ireland, we would have politicians and policymakers who might release a new policy based on political agreement or trying to get support from their candidates. So they would release a policy, they would look at some indicators, and they would deploy the policy. But they would never really review, did that policy make any difference? Was it beneficial? And what are people's views on it? So we're trying to change the whole process. So the policy review starts, look at your data. Does the data tell you that we need this new policy? Is it a problem? Are we going to save efficiency or enhance people's lives? Then the assured governance, collecting the key indicators and identifying the sources of data. We want to explore and simulate the models and let people learn from that information. And then evaluate, come back when you release the policy, come back and evaluate and close the loop right round. And it may find that it's a couple of iterations of that process, or if it's a very lucky policy, it might work first go. Again, I'm not going to spend too much because I know Mina and Peter are coming up later. So one of the key things for us is to really learn from Finland about this approach about My Data. They're quite far ahead across Europe, and they have a lot to offer. And we think it would be beneficial if local citizens could take consent for themselves and volunteer their data for the richness of the research. Again, this just gives you an overview of the project. I'll not spend too much time on this. So this is really the iterations that we're going to deploy to the policy people. There are going to be 3 deployments of the platform. So we started off, the first one will happen about month 18, and then 12 months later we'll have our second one, and then we finish off on month 18. And the whole way through we're applying the agile process because we've got the policy board on board, and they've been to most of our meetings. So most of the executive board meetings we've had, or the quarterly meetings, the policy board have been there, and we can use them to get our user requirements and get feedback on the tools, and also just to try and identify their data and the types of data they're bringing to the problems. So we have sort of 8 work packages going across this. Standard 1 is just project management. Work package 8 is a new one. If anybody's putting in a Horizon project, beware, this is now automatically added by the portal, even though we had an ethics work package. Work package 2 is really where Southeastern Trusts are going to lead, and we're looking at governance, consent, ethics and privacy, and we think we could learn a lot from each other across Europe and try and get a more consistent look at that. Vicom Tech are leading work package 3, which is looking at the architecture and the data sources, and again what richness we can get out of that. KU Leuven then in work package 4 is the data analytics and simulation, and work package 5 is the visualization for public health making. And what we're finding out of this project, work package 3, 4 and 5 are really working closely together, and it's having a real added benefit. That knitness of those 3 work packages is working really well. DCU then are leading on the evaluation and impact assessment and making sure everyone's doing the right job for the right outcomes. And then Ulster themselves just the dissemination and exploitation. Work package 8 is basically including what we were already doing in work package 2. So the policy board, as I mentioned, again, is our health partners. We have a chair, Jonathan Wallace is here today, and our deputy chair, Paul Carlin, and we have co-chairs with Roberto from BioF and Peter here from VTT are involved in sort of managing that policy board. And again, the richness that they are bringing across the different areas is really good. Again, ours owned Escape University, we want to look at the lessons learned there from the US and the healthcare model, the private and the public sector. PHE have done a lot of work with publics and working with consent and bringing that in. And BioF again are looking at, they have a biobank, and we want to look at how they're using that, and again the ethics and considerations around that. Finland, as we've mentioned, there's healthcare data, but also that My Data being brought in on top of that as well. So we have THL and Ulu. With the My Data, and then BSO are representatives from Northern Ireland. We're going to look at children at risk first of all, and HSC from the Republic of Ireland are going to be looking at diabetes. The policy board is, to me, a real strength. It's an open source platform from a strong technical team, so they're going to get a big data virtualization layer, that connection. They will be getting analytics, and they will get visualization, and this is deployed on site for 4 of the key partners. Digital e-learning packages, so we're going to look at how we can upskill the people within those trusts so they have the business intelligence, they know the data inside out, but don't have the skill set to use the platform. So how can we upskill them? So part of the project from Work Package 7 is also looking about developing e-modules, understanding of analytics, how you can use these tools and how to use them appropriately. And one of the other requests that come through today is really people at a policy level probably need a bit of education about what is the impact of this tool and how to get the best effective use out of it. So we're going to be looking at distance mode modules. We also have a new MSc deployed in Ulster that's about to start in September because we've identified a real need for the skill set, so that's about to kick off in September. We're sharing and learning from Europe and the policy board partners. We're going to share findings. We've potential comparative policy studies being identified. Again, sharing of best practice and enhanced policies, and again, these new initiatives such as MyData and how we can roll that out across Europe and do a share and compare. So we also have the process that we can actually do a comparison across that. Again, we started in November 2016, so we're quite fresh, but we also had some great gains to date. Great technical progress bespoke to the policy board members. They are a very diverse group, needs across Europe, and again the technical team have been working with them very well and asked them, and they have the opportunity to have bespoke visualization and analytical opportunities, and they've had some demos of those this morning. We have other research associates and PhDs involved in the project and self-funded, so some of the universities have match funded those and brought those on board, and again they're working in parallel with the technical and academic teams. We've got a test platform that's about to be hosted at Ulster so that the people can get access to real live data and start deploying some more of these case studies. And we've got a TUDA test data set coming from Ireland, which joins the North of Ireland Republic of Ireland data, and it's looking across the two, and some diabetes data and some more to come. And we've had some great networking across both at a policy level and at an academic and technical level. And we've had some fantastic meetings in Brussels and Bilbao and just in different interests. And one of the things that we found with that is that we've got extended interest from quite a wide range of people about how they can come on board with the MIDAS project, how could they maybe join the policy board. So we've some interest there already from Spain, from the Bilbao event, and we've extended UK partners who've just been in touch with us from the likes of Wales and Scotland want to come on board as well and see how they can join in. So in a very short time we've been able to turn around quite quickly and hopefully it continue. That's just an overrange of the consortium partners, and that's me done. Thank you very much. And Mina, isn't it next? Not that one. It's behind it. Oh, I picked the fourth one. Okay.
Okay, hello everybody. My name is Minna Pikkanen. I'm Connected Health Professor working for VTT and Ulster University. And today I'm going to present you the Finnish case of our MIDAS project. And this presentation we have made together with Peter Ylen, who is working also in VTT, and he is the professional of systemic modeling and impact analysis. I'm a specialist of health services myself. Okay, and about the Finnish case, I'm going to tell you why, what we selected as a case and why we did that, how we did the case, and what we have been doing so far. So very simple structure. What is happening in Finland currently, we have this health and reform ongoing in Finland, and this is causing a big change in the healthcare sector basically. So all the responsibilities in the healthcare sector are changing. We are changing from this big amount of municipalities and hospital districts. All the decision making is going to the counties who are then making the real decisions about what is happening in the health and social sector. And basically if we look at the decision making systems in the different areas, we can see that they are varying a lot between the different municipalities and hospital districts. So everyone has kind of their own systems to be used there as a behind. And some of them are more advanced and some of them are not so advanced. And basically what is now critically needed is some kind of data-driven support systems for the decision making in the county levels when all this change is going to happen. And then as a case here in Finland, we selected actually preventive mental health for children. And actually why we selected that was that when we discussed with these policymakers in Finland, they said that this preventive mental health or mental health problems are increasing dramatically in Finland. Basically in worldwide there are 20% of the children has mental health problems so far, and 1 of the 4 children are bullied in the schools in Finland who are 13 years old at the moment. And basically what it is causing is that these children, because they are depressed, they don't have motivation to study, and then they leave out of the jobs in the future. And actually supporting the employment of these young people is one of the key strategies of the Northern Ostrobothnia area in Finland, and that's why we selected this case as a target of this decision making system support in the MIDAS project. And what we studied actually was that how this different heterogeneous data, so-called rich data, can be used in the decision making of the policymakers in Finland related to this preventive mental health cases. And what is actually new in this case, new aspects that we were looking at are actually the preventive side. So mainly, most of the times these decisions are made based on something that has already happened in the municipalities or in the cities. But basically what we wanted to look at is the preventive side, like what are the risk indicators leading to these problems, and to help these decision makers to see the problems earlier, and if they, for instance, allocate resources or the services in some certain areas, what will be the consequence of that. We use the system dynamic approach and a multi-actor perspective to see what is happening. So what do we mean by this system dynamics? Is that we look these cause and effect relationships, we look the forecasting of the problems, and we are simulating how this decision making will look like in the future cases. And what we did actually, we did expert interviews in the Finnish ministry in the Northern Ostrobothnia area, and also in the different areas under that, in order to understand how the decision making is happening currently and how it should happen in the future if you use the data as a behind of that. And then we were kind of creating the baseline for this simulation model that we are building in MIDAS based on that. And basically not only interviews, but we also had workshops where we defined this cause and consequences together with these experts. And what we found out was that, like I said, this decision making is varying a lot in Finland between the different areas even. And in some areas they were making actually decisions using very historical, like 2 years old data, with using very few amount of data, which is collected mainly manually, and decisions are mainly made based on the current problems. Then in some areas, like Oulu City, for instance, they were quite advanced in the decision making already. So they were using kind of monthly basis updated data sets, and also multiple data behind the decisions. And also they were also looking at some correlations between the different data sets already. But also they were also looking the problems mainly based on what has happened already, but they had an intention clearly in many areas in Finland to go more towards this preventive side, really to understand the risk indicators and what is leading to what in this decision making. And what was the kind of goal of these decision makers then? One thing that they mentioned was that this personal data and the MyData approach would make it possible to see kind of a digital footprint of the people and understand in individual level what is actually leading to what, making more kind of correct analysis of the situations, for instance, which services to allocate which areas. And also, if the family situation is affecting to the mental health of child in the long term and so on, these are kind of indicators we could get from that. They also said that they would like to have these clear visualizations because there's huge amount of data. They want to see clearly that what is the relevant out of that and helping them in the decision making. And the preventive impact analysis was mentioned there as a key target, so that we use kind of as real-time data as possible to make the decisions, but also this historical data as a kind of reference what will happen in the future in there. And we also got a lot of kind of requirements from those policymakers of how this decision-making visualization should look like and so on that we collected. And actually, based in the workshops together with these experts, we built this kind of visual dependencies between the different risk indicators and what is leading to what in this mental health area of children in Finland. We also defined what are the data sources related to those different indicators that we defined. And here's one example of these consequence indicators that we defined. So school motivation, how it's affecting the school performance, and then to the unemployment of the person, for instance. And this is a picture of the huge map that we actually created out of that. And basically why this map was created is that based on this map, we can then make this concrete simulation of the data-driven decision making. And our plan is actually to validate these data sources with those policymakers, what is relevant for them. And also when we do this simulation, to show this simulation in practice and then collect feedback that how it should look like and then iteratively improve this during the MIDAS project. So this is basically the end result then what we get. So thank you. Marita.
Okay, thank you. Is there anything? Okay, so good afternoon, ladies and gentlemen. My name is Marita Berälahip and I'm a director of Center for Health and Technology from University of Oulu. And I'm telling you about my data potential and in fact giving a short introduction about my data in healthcare. We already heard this afternoon Taru Rastas telling about my data in Finland, but I will give you some examples of what we have been working here and then binding this story to this MIDAS project. So I have been leading digital health revolution in Finland for 3 years. It is a 10 million program. Tekes funded 7 universities involved. And we have been looking at how the personal data could be integrated in healthcare systems in the future. And in fact, during this program, we have been defining a different type of data management models. And in fact, we think that only way that we can change and reform healthcare is that we have to also change the management models. At the moment, you can see that there is a different type of models existing. In our mind, my data model will solve quite many problems in healthcare and also in other sectors, meaning that in fact people will be in the center and control of their own data. As you see that these other aggregator models and API ecosystems, the people are not in the driver's seats as we see that they should be. At the beginning of the program, we were defining MyData principles. You heard them already from Taru's presentation, but just summarizing what we mean by that, so that individual is in control. It is a transparency to personal data usage and also privacy and trust and usability of data. It's not enough that we have access to the data. We have to be able to have the data in such a form that it can be transferred between different services. And we are building, and we have been also studying open business environment so that we can change the services without data logs. And if we look today how the healthcare system is functioning in Finland, I would ask you and all of us that are we still ignoring the power of the personal data? I think that at the moment in many countries at the European level we still have that healthcare system which is mostly focusing on treatments, and I think that the power of the personal data will come in power if we are also thinking about that we could start focusing on preventive side. And in fact this is also showing that if people can have a rich analysis of their own data, if they can own their own personal health account, and they have tools and technology to transfer the data between different types of service providers, not only for medical doctors but also for health coaching and so on. So it will be a totally different environment. And I think at the preventive side, if we have very early intervention and the people can understand their health status, they can also change their lifestyles accordingly. And of course now MIDAS in Digital Health Revolution program, we were not looking too much about this analysis side. We are running at the moment pilot with 100 people, and we are analyzing the data. We've been analyzing the data from the genomics to the digital footprint, and we will be getting results from them in a couple of months, and this will be very interesting results that we should be focusing on, that how this rich data is in fact also returned to the customers. We are also modeling that in that pilot. But if we go to the big data and thinking that how in fact and do we have a preventive value of personal data when it is associated with big data. This is quite big discussion, and in fact when we started in MIDAS we were able to understand that what type of data we can combine and what is the value on that. We are working on meaningful analysis of data in MIDAS. So if we think individuals, people, for us it might be meaningful to be able to compare that how we are performing if we have risks of having cardiac diseases or risks on that. It would be valuable for us to see what is the status, and it would encourage us also to change our lifestyle. But there's also some other ongoing activities in Finland which are related to MIDAS, and these are all very well aligned with the radical healthcare reform which is ongoing. We have a government's key project which is self-treatment apps for Finns, or you can call it like that. It's a new service model in healthcare and social services, so that in the future we would have, municipalities would have a role to make a healthcare plan for people. And then if we have this plan, we are also collecting and communicating our caregivers about our well-being. I think that this program, which is now piloted in 14 cities in Finland, is one very good connection point to MIDAS, because this can be in fact validated data, collected data that we can also combine with the big data. We are also having a secondary use of health-related data program going, and the legislation on that is going to be in power in a couple of months. But if we think about my data and in policy making, it's not very easy, in fact, in my mind. Of course, this is the study that we will be doing now during this program. But as it is that at the moment we are not using personal data in healthcare system as well as we should. I would say that also policy makers, they don't even understand how to use the personal data. In my mind, personal data, it can be a resource in policy making, and we can call it my data only when the people have control on that data, so that we have a definition there. We have to remember that. We have to look at the legislative framework and also ethical consideration when we start using the personal data in policy making. And if I look the how we can choose and define our use cases for the database decision system in MIDAS, if we look at provider-centric database decision system, the municipalities, I guess that they are willing to do and improve their care pathways, outcomes of the care. They are willing to see the prediction for the need of care and care deficit, and also maintenance of community well-being. And of course, I hope that they are willing to see that how we can get database service innovations. If we look at only on the person-centric view and the database decision system, so the assessment, it is mostly prediction of the risks, maintenance of well-being, and there is a possibility to build up my database services. I think that we should have a combination of these two in MIDAS, at least in our mind, because we shouldn't think that policymakers can make us healthy. We are also players in this game. So the work that we are investigating in MIDAS is that we are carrying out analysis about the potential need to use my data in policy making to gain evidence on the assumed benefits, and usage of my data in decision making to gain evidence on using and the value of big database analysis. And if I looked at what's happening in Oulu and this pilot that Minna was telling, this healthcare and social reform going on in Finland, also in the regional level, City of Oulu is looking the new data development models. And of course, they want to improve the welfare tools to predict the changes in community welfare. And one of the pilot cases that Oulu is leading is they want to know more about the information about heavy service users, if you can call them like that. And they are willing to do pilots of new data management model for social care as well. So I think that MIDAS is now serving City of Oulu now very well. But we have to remember that if we are looking at these use cases, whatever in MIDAS, we are still having policymakers in the certain attitude and mind setting. They are looking still at all old data that they are usually using, statistics, registers and so on. They are mostly, in fact, they are interested in services which are what are the needs and how effective they are. They might ask even citizens if they are satisfied to use services. But when we build up and we are combining different type of data, real-time information and personal data on this picture, so we have to remember that it's not very easy task for us. Already the challenges in data practices and data in silos and so on. And I think that luckily we have this consortium here, but we have to bear in mind that this won't be an easy task. Thank you. I want to okay, thank you.
Thank you very much, Marita. Thank you, guys. I think that's been a fantastic presentation, and I'm going to finish off in the last 10 minutes with trying to move. Well, I have a few quick slides, but really I want to finish this off with actually some data and some pictures and some words rather than slides. So to very quickly just start out, I have a couple very brief slides to talk about what data I'm going to show you. And it actually ties in very well to the previous talks. So ultimately what we're looking at in MIDAS is integrating data and getting meaning from it. Now, Mina and Marita both talked about mental health, and in your last slide you mentioned welfare and issues around that. And that actually directly reflects on what we're looking at in this demo. This actually stemmed out of looking at Northern Ireland's programme for government, in which two of the key indicators were looking at health inequality and mental health. So these are policy areas of interest across many European countries, and actually are areas of interest within most of the consortia in MIDAS here. So what this project set out to do was to say, using open data, so none of this is data from within the health system other than that has been released openly. What can we get using open data, using statistical information and easily available information to show a link or to show something about healthcare, and specifically looking at mental health and health inequality? Now, this seems like a relatively simple question, and it seems like it should be quite straightforward to do, but it turns out that the data sources are, as I mentioned in my first presentation, the data sources are very siloed. So to answer this question, we got information about the primary care practices in Northern Ireland from HSC. We got the GP prescribing information from Northern Ireland, which is anonymised data on what drugs have been prescribed, and we got that from the Service Organisation. We also got information about English prescribing data from NHS Digital. We looked at employment data, population data, deprivation data, and census data from the Northern Ireland Statistics and Research Agency. We took the English census data from the Office of National Statistics, the Northern Ireland boundary data from Open Data NI, and the UK postcode data from mapit.uk. Now, to answer this simple question, we have 10 data sets from 6 different data sources. And I think that this is not in any way unusual. This is exactly the kind of thing that you kind of expect to see. That to really get insight from this, you're looking at relatively complex data structures.
You're worse than me.
Huh?
You're worse than me.
I have so many tabs open. I know. So really, this is the kind of thing, this is an example of the kind of thing that we would expect to get from the MIDAS project. What we're showing here is where we have actually pulled this data together and shown, particularly in this case, looking at mental health and the link between mental health and socioeconomic status, using percentage unemployment in the population as a surrogate endpoint for socioeconomic status. What you see here is a list of all of the antidepressants and anti-anxiety medications used in Northern Ireland. And what you see here is a correlation between the percentage unemployment claimants in a region that we've got mapped above, along with the number of prescriptions per 1,000 people. And as you can see, we see a fairly straight line. So as a positive control, this is something that we expected to see. We expected to see a link between mental health and socioeconomic status. Now, Mina made the point earlier with what they had shown. This is the classic post hoc ergo propter hop. Correlation does not show causation. So all we're seeing here is that there is a correlation between percentage unemployed and number of people on antidepressants. Now, whether those people are unemployed because they have mental health issues or whether they have mental health issues because they're unemployed, we can't conclude on that. But we can show quite clearly that there is most definitely a link. Now, when we look at this information, again, what we will aim to do in MIDAS is that we'll be making this data interactive. So if there is specific drugs that we're interested in, we can zoom in on them. And one of the things that we found from this data that was quite interesting is that the two most commonly prescribed drugs in the list are venlafaxine and mirtazapine, which are SNRIs, serotonin noradrenaline reuptake inhibitors. Now, I had always been under the impression that the most common antidepressants were SSRIs, and when I found this, I went and looked on the NHS website and found that the NHS website tells us that SSRIs are the more commonly used drugs. But when we actually look at the data, it turns out that that's not the case. It's actually SNRIs in Northern Ireland anyway, and when we went and looked at the English data, it turned out to be the same thing. So again, this is interesting that it allows us to get insight that we might not have otherwise seen. We also see that the worst place to live in Northern Ireland is West Belfast. So if anybody's been to Belfast, you'll appreciate that this is actually true. And I'm allowed to say that because I'm from here, which is just next to West Belfast. But on the bright side, I have moved from here, North Belfast, to here. So I have clearly moved in the right direction. From here to here. I made the right choice to make that move. One of the weird exceptions in this, and I've mentioned few people in the room have heard this before. We have an outlier in this data, Foyle, Derry, where Michaela is from, where everybody is really happy to be unemployed. You can make up your own reasons as to why that is. We have never really got any good insight on that. When I first did this, one conclusion that someone facetiously mentioned was perhaps they all self-medicate with alcohol. And that's actually why I added these drugs instead of just these, because these are what are used to treat alcohol addiction commonly. So it turns out that they're not self-medicating. When we look at this, though, one of the things that I found most interesting is that this is a single variable that we're looking at. We're looking at unemployment claimants. One of the things we then looked at was a thing called deprivation measure, which is generated by the Northern Ireland Statistics and Research Agency, which includes about 20 different key indicators that tries to look at overall quality of life. So it looks at cost of housing, availability of housing, green spaces, play parks for kids, and percentage unemployment. And what you see here is that Foyle actually then falls back and moves back into that line, and if anything, the trend line that here would indicate that any increase in deprivation actually leads to, or is correlated very strongly with an increase in issues with mental health. Now, I have a number of colleagues in here who have seen me present this data multiple times, so every time I do it, I try to do something a little bit different, just for Johnny. And when we were talking about this morning, one thing, and again, I think this reflects quite well, one of the things that is being looked at in Northern Ireland from a policy perspective is in Northern Ireland, we give free prescriptions. Now, when we correlate our data with England, we see that quite dramatically, we use a lot more drugs than England, okay? Northern Ireland wins the drug taking competition against England, across everything, but ultimately it seems quite likely that that might be related to the fact that we get free prescriptions. Now, when it comes to these free prescriptions, this includes anything across the board, and that includes things like paracetamol and ibuprofen. Now, these drugs can be bought in local supermarkets for around 20 cents, whereas getting them on prescription costs the health service £5 or £6, £5 or £6, €7. So it seems that it's perhaps a bad idea that we're giving away drugs that are verging on free as free prescriptions and costing the health service a significant amount of money. So what I actually looked at earlier was to see, well, how much of an impact would this actually be having? So what I've got here is a list of the top 20 most commonly prescribed drugs. And we can see that ibuprofen is the 11th most commonly prescribed and paracetamol is 13th. So these are actually very commonly prescribed drugs, but they cost virtually nothing to buy in a shop. So people are getting prescribed these drugs. The key question is, are people doing this across the board, or is this again a reflection of socioeconomic status? So I went and added these drugs this morning, ibuprofen, paracetamol, and as you can see, there is a perfect straight line indicating that the people who are using prescriptions for paracetamol and for ibuprofen are, for the most part, have a lower socioeconomic status and have issues or are unemployed. As a correlation, this is the percentage of the population in these areas over the age of 65. This almost acts as a control to show there is no trend here. There's no association with age. There's clearly an association with percentage unemployed. And because we're running quite short on time, I want to just highlight one more. I added a few other drugs the other day that I hadn't looked at before, so I decided to look at the statins, which are a significant cost to the health system, and I'm sure a lot of people in the room know are probably not the most effective or necessary drugs. And again, with the statins, we actually see this fairly strong correlation with unemployment claimants. Now, what that would tend to indicate is that there's a lot of correlation between drug use and socioeconomic status and deprivation. And what we actually have here is a correlation matrix looking at the top 50 most commonly prescribed drugs in Northern Ireland. Blue indicates positive correlation, orange, red indicates no correlation, negative correlation, and we're looking at three things. It's percentage unemployed, deprivation measure, mean age, percentage over 65. And as you can see across the board, every single one of the top 50 most commonly prescribed drugs is linked to deprivation and unemployment, and 4 are linked to age. So ultimately, when we look at this from a policy perspective, giving free drugs does result in people using more drugs, and that perhaps opens the question of should we look at the health outcomes and the health economics of that. Giving people free low-cost drugs like paracetamol, ibuprofen results in them getting them on prescription when they could buy them in the supermarket, so perhaps we should look at modifying that. But ultimately, when we come back to the issues around health inequality, in Northern Ireland we clearly have very strong issues with health inequality, and poverty does lead to significant health problems. Now, I could talk about this all day. I already did briefly show the issues with England. And just to say one thing positive about Northern Ireland, I had to look really hard to find something in which Northern Ireland didn't win. And it turns out that we eat less gluten-free bread than one place in England. And on that I'm going to conclude and finish. Thank you very much. So at this point it is a small room. I did want us to get through the talks, but does anybody have questions for any of the speakers today? Please raise your hand. Paul.
So you were talking about AKI in terms of the Google.
Yeah.
And actually we did a piece of work in Southeastern Trust, and we have an algorithm. So it's a paper-driven algorithm, and it's got 5 fields in it, and that has reduced our incidence of AKI by something like 70–80% within a 6-month period.
Yeah.
You don't need to do huge pieces sometimes of analytics and actually look at, aggregating data. Sometimes the solution's right there.
Yeah.
It's about process and actually education, particularly for clinical outcomes. So it's really surprising that Google, and now the evidence is out there actually, but focused on something like that. There's more to it than the AKI, I would hazard to guess.
So there is, and I will preface my comments with the fact that I do not work for Google. I have never worked for Google, and most of what I'm saying is conjecture. But Google got a lot of coverage for how they were using artificial intelligence and machine learning in healthcare. But what they've taken is very, very low-hanging fruit. They've taken a problem where patients get AKI in hospital regularly. It leads to deaths, and it's incredibly preventable. What they're actually doing with Royal Free is polling test results and notifying people of a failed test. That's actually all they're doing. If you trawl through DeepMind's website, there is frequently asked questions, and one of the frequently asked questions is, are you actually using machine learning and artificial intelligence? And the answer is no, we are not. Now, despite the fact that they've got a lot of coverage for using AI and machine learning, they're not. They're just pulling results and sending notifications to doctors saying your patient has an AKI. As you said, it's the easiest solution because it will work. The problem is that the doctor has to phone down to the labs before they give them the next dose, and someone might forget and the patient might end up dead. But ultimately, they've chosen a really simple solution, but, and again, pure conjecture, I would imagine that they are using this database, that they are developing this corpus of data to train itself and identify AKI before it occurs. And that's the part where that then takes a jump beyond. So again, this is a win-win for them, apart from the negative press, which is also a win because they get loads of coverage. It's a win-win because initially they identify the AKI now, sooner, and help the patient, and they develop a system that will, in the future, help them identify AKI even sooner and actually give them a stronger differentiation. So, but again, pure conjecture on my part. Any other questions?
I think Google set back the cause of health data by about 5 years by their reckless behavior. I'm fairly confident they're going to be sued. I'm fairly confident they're going to lose. And I'm fairly confident that will freeze out anybody else who wants to do the same thing. And it's a pity because I think you're right, and I think that is pretty much what they're doing. Their suggestion that they're doing this as a fast way of paging you about results is childish. And that's been done by EHR systems for 25 years. You know, there's no innovation there at all. But they are damaging everybody. They're damaging their business, and they're damaging everybody else's.
I agree with everything you said except for the fact that they're damaging their business, because I don't think that they are. I think Google were very aware of what would happen. I think they're aware that they'll be sued. They're aware that they will lose. And what they will be billed from this is going to be a drop in the ocean, and they won't care based on the exposure they have. Had anyone in the room not heard of the Google DeepMind Royal Free project? Can I show your hand if you hadn't heard of it? That says not a single person raised their hand. They have managed to get so much PR that everybody knows about this. And this was a little startup from Oxford Cambridge that Google bought.
Is that when you come along asking patients for their permission
Mm-hmm.
to include their data,
yep.
they'll refuse.
No, absolutely. No, that's what I'm saying. I agree with everything else you said, but I think Google knew what they were doing when they did this.
The consequences of that for everybody else in the system
yep.
are severely negative. The other thing I draw your attention to is that you must have a hell of an oxycodone problem.
I usually do talk about the oxycodone problem, and so I suppose since you've drawn it up, it seems that everybody in Northern Ireland is addicted to opiates because this is oxycodone and tramadol, and if you were to add these two together, it is far in excess of the most common prescription, salbutamol. Again, if I look at the actual data on this, this is our top 20 most commonly prescribed drugs. Just under salbutamol, we have cocodamol, pregabalin, oxycodone, and tramadol. So Northern Ireland really, really likes opiates.
That's enough for everyone in Northern Ireland, nearly.
It's a lot of prescriptions for opiates, but they're addictive.
And is that, have you done that by age as well? You know,
this is all completely anonymized data. So any aggregation that we're doing is based on people within a region. So again, if we were able to get access to the data and look at who these people are, we did see an association with age with fentanyl, where it's clearly being prescribed much more in people over the age of 65, but I think it's because fentanyl is, well, if you're taking fentanyl, you're not doing much else, whereas oxycodone, technically, you could go to work.
So you were saying that one of the, I remember the first time you gave the presentation, and I see you included England as a sort of control.
Yeah.
So the idea was to show that you're so basically saying the list of medications similar. The list of what's prescribed is similar in England too, so it's not a unique prescription list, it's just the amounts.
Yeah, although it's notable, England take an awful lot more morphine than we do, which I thought almost felt good about until I realised it's because we take all of the oxycodone and tramadol instead. I think it's quite dramatic. This is Northern Ireland compared to everywhere in England.
Compared to say some of the other interests and the other stakeholders in the consortium like Finland say in
Yeah, I mean, it ties in, you know, you guys were mentioning you're looking at intoxicants and mental health.
Yeah.
I've spoken to primary care GPs who are aware of this kind of problem, and they know that part of the issue is that the people that these drugs are being prescribed to are from, it is also linked to socioeconomic status. These people have not got the best lives, and the doctor sometimes is just signing off the prescription knowing that they're going through a tough time or whatever. So any further questions? Any for any of the other speakers, please? Okay. Okay, if that's everything, I would like just one final point. I'd like to invite the chair of our policy board, Johnny, up to the front. Paul, can you come up as well? We just have a small presentation for Johnny. Despite his youthful demeanour, Johnny is just about to turn 50, which makes me feel young for the first time ever. There we go. So Johnny, we just wanted to publicly embarrass you and wish you a very happy birthday.
Thank you. To our entertainment officer. There you go. Thank you very much.
Happy birthday.